Oh, is it back? Ah, microphone's on. Just seen there was I get these like equalizer lines on my microphone, and it was just nothing. I was like, oh no. Morning, Steph. Morning, Martin. Good to see you back, Martin. Nice to see you on camera this week. You wouldn't have wanted to see it last week. Definitely not. So we're going to finish off the shoulder girdle muscles today, and then move on to the rotator cuff. Just had a message there from Martin that there's no sound, so hopefully it's back on now because it looks okay my end. So if you want to just give us a nod to say that that's all good, and then we'll crack on. Morning, Claire. I haven't seen you on here for ages. Well, I'm not making comments anyway. You might have been lurking in the background. It looks as if everything's okay. Right then, let's get going. So we are just going to do a bit of a recap from last time. So we were here. We were looking at these shoulder girdle muscles, and so the way that I kind of distinguish between the two. All good. Thanks, Martin. The way that I distinguish between the two is these are the ones that attach the shoulder blade to the rest of the body, and they bring about the shoulder girdle movements, which are things like elevation, depression, protraction, retraction. So all those movements that come from the sternoclavicular joint, and what muscles are involved in moving the girdle in that way. And then I've separated that from the cuff, which is the bits that attach the scapula to the humerus. Okay, so that's why we've separated the two. No worries, Claire, no problem. We went over these last time, so if I'm going to skim over these, and if you want them in a bit more detail, then have a look at last week's session. So we've got some useful words, things like serratus, which means serrated, and there's a muscle called serratus or serratus anterior. Latissimus means broad. Dorsi means dorsum, which means back. Deltoid is a triangle, like delta. Rhomboid is like a skew-if rectangle, so a rectangle that's kind of been shunted, hence the shape of the rhomboid muscles. And then the trapezoid is like the trapezius, or trapezium, anything like that. It has a shape like like a trapezoid, something like the shape up here. Okay, so that's just a quick recap of those. We looked at the trapezius, and we looked at the various different actions of this. The upper fibers, mid fibers, and lower fibers all contribute to different movements. And we were talking about something called upward rotation. Just get my shoulder joint here. So upward rotation is when the scapula moves up. Well, in fact, it's mirrored. So let me do it another way. So as you bring the humerus up, you'll get to a point where it won't go any further, and then the shoulder girdle will then start to move. Okay, so this inferior angle will move that way towards the humerus, and that's upward rotation. So if you think about what's happening with the trapezius muscle that attack, so from this picture here, attaching up into the neck, when those fibers contract here, it's going to pull this end closer towards the neck, and then this end will then, along with some other muscles, help guide the shoulder blade scapula around your rib cage. Morning, Ellie. And Martin's just said latissimus dorsi, such an undervalued muscle. Clients never come in and ask me to work this, even though it's an easy one to work on. Yeah, it's especially shoulder issues, which because the attachment is really close to where the pecs are, where the pec attachment is, and where the bicep tendon is. So sometimes you can have a bit of a lap issue that's you think is some of the other structures, but it may be the lat attachment. Yeah. And then these middle fibers, because they come straight across, they'll retract your shoulder blades, so they'll bring your shoulder blades back together, and then the lower fibers will depress your elevated shoulder girdle. Okay, so it'll bring it downwards or into further depression, like a hyper depression, really. So from a normal position and then down. We're going to, over the next couple of weeks, we're going to talk about the brachial plexus. We talked about that when we looked at the neck, but also the blood supply that comes up through this region as well, and the symptoms that you might get with thoracic outlet syndrome. So we'll go over that again. And quite often these muscles are blamed for those kind of problems. So we'll look into those in a bit more detail. So yeah, we looked at trapezius, we looked at levator scapula, and the fact that the levator scapula has a mechanical advantage when you're shrugging. Okay, so it attaches onto this bit, superior angle, and then onto your neck. And then if that contracts, then it's going to elevate your shoulder girdle. Okay, if the upper trapezius contracts, it will bring about that kind of movement, so that upward rotation movement. And this is why if you're doing shrugs in the gym and you want to target the upper trapezius, best thing to do, we were talking about this last week, is do a monkey shrug, where you abduct the arm so that then upwardly rotates the scapula. That then aligns the shortens the fibers of the trapezius, lengthens the levator scapula, and now the levator scapula is going to find it really difficult to try and elevate that scap because it's at end of range, whereas this trapezius muscle is in a mid-range position. So now we can get elevation of the shoulder girdle and more focused onto the trapezius muscles. And if you've never tried it before, give it a go. It is a trap burner. Okay, it really is. So just bending the elbows up. You can tell I'm a kid who grew up in the 80s. If you're somebody who grew up in the 90s or 2000s, then apologies. But have a look back at the Beano comic, and Dennis the Menace used to do this pose where he would make an M kind of shape out of his arms. And if you imagine doing that shape and then shrugging from there, that's a good monkey shrug. Okay, so it's a Dennis the Menace M. That's what you need. Okay, so yeah, we looked at levator scap, we looked at rhomboid major, and then its partner in crime, hopefully next one, rhomboid minor. So these are next to each other. So minor on top, major just below, and they are those rhombus type shapes. Okay, so we've got a slanty rectangle. Okay, so that's where they get their name from, and you can see the direction of fibers. So if it attaches from there and goes to there, then it's going to make the shoulder blade go upwards and in. Okay, so up and in. There you go. Elevates and retracts the scapula. That's the scientific way to say it. Exactly, Claire. Exactly. Was never a member of the Dennis the Menace Club, though. I was gutted that I never did that. I was too poor to join when I was a kid. So we've got lat dorsi coming in here, the one that Martin mentioned earlier. Massive muscle attaching down into this connective tissue down here. Now, we would have talked about this a lot in the lumbar spine. It's called the thoracolumbar fascia because it joins the thorax to the lumbar region, and it is a big kind of web of connective tissue. It's where muscles attach into, in particularly in this case the lats, but the glutes will attach up into there as well, glute maximus. And but basically, it's one of those things where I think sometimes it's often blamed a bit too much for things again. You know, we kind of look at things and go, oh, it must do that because it's like simplicity means that the lat works with the glute, and then there's thoracolumbar fascia in the way, so all of that's got to be connected to like sling systems, and it's not as simple as that. Basically, if you train in that way, it's a great way to train, and you can help a lot of people by doing it, but sometimes for not the reasons why you think is happening. Basically, so but if you just did exercise, then they'll get better, and they don't need to do something specific like some kind of crazy cross pattern and stuff. So we've got lats coming up into the anterior part of the humerus. on the intertubercular groove. There you go, intertubercular groove just there. And that is the place where the pec will attach into, around that region as well. And your biceps will come very close to as well. So it's on the front of the arm, basically. So your lat attaches onto the front of your humerus, and it twists as it comes up, and we saw that on the video last week. We then had a look at teres major, which is lat's little helper. So this does the same job as lat's, okay, crest of the lesser tubercle, so it comes across onto a similar kind of area, attaches in there. No twist on this one, so it's yeah, it just kind of goes across and attaches onto the front of the humerus. So that's teres major, and then I think that is where we got to. Yeah, because we definitely didn't do this one. Okay. So when you do anatomy quizzes, and the quiz is how many muscles attach to the shoulder blade. Now you'll know, after doing this this session today, that it is 17, and this is one of the muscles that often gets forgotten. And can you see where it attaches onto? It attaches into your throat. Okay, so you've got a muscle that attaches onto the bones in your throat, back onto the top part of your shoulder blade, onto the scapula, just there. So let's have a look at this one, because we didn't see that last time. Let's get rid of those. Stack this one up. Hopefully this is it. Excuse me. Here we are. So omohyoid. So there's your attachment points again. And here it is here. So if I just pause that there, just get rid of that. Where's that gone? Wait a sec. There we go. Okay, so we've got the collarbone just along here. Okay, so that's your clavicle. So this is looking at the front of a right shoulder on this particular video. And thankfully, my microphone hasn't cut off this time. So let's have a look at this omohyoid. We can see a slither of muscle coming through there. There's your sternocleidomastoid, superior part of the scapula. So it attaches kind of midway along, and there it is there, look. And that's where it attaches up there. Oh, that was really quick. Let me just go back again. Okay, so that's going through onto the hyoid bone, which is that horseshoe-shaped bone near your thyroid. So up there. There you go. Can you see it there? Oh, that's really quick. I'm just going to pause it on that spot. So it gets to it and then just cuts off. There we go. So omohyoid, sternocleidomastoid in front. There we go. That's it. Yeah, it's a hyoid bone there. These are all the inferior hyoid muscles. We talked about those, did a whole session on the hyoid, so you can have a look at those in more detail. Sternocleidomastoid, we covered that quite a bit when we were looking at the neck and the scalene muscles around here, and there it is just poking through there. Yeah, so it comes through there and then backwards onto the middle part. In fact, you can see it on this model. You see that there? There's a little red bit where it shows where it attaches just there. Okay, so that's the attachment point for your omohyoid muscle. Cool, so that's that one. And then we're looking now at the front of the shoulder, and so I've split them into posterior muscles, anterior muscles, and then lateral muscles. So the anterior muscles we're going to have a look at is, or one of them is pec major. Although this doesn't attach onto your scapula, attach onto the humerus, it has a role in movement around the shoulder region. Okay, so obviously in this case the glenohumeral joint. So we've got the things that it does, but again, look at the different types of fibres on the pec. So we've got clavicular fibres up here that come in this kind of oblique down direction. These ones that are more sternal fibres coming across here, and then these costal fibres here coming up. And then they all come together and kind of twist, yeah, and they go over your bicep tendon. So there's the biceps groove just there, and they go over that bicep tendon and then attach onto the other side. And there's like a valley where the bicep tendon will come up through, and the pec will cover it. All right, so it'll be one of those things that that is covered. So let's have a look at that. I've got it here. Here we go. Yeah. So we've got the lat and the pec together on this one. I think we had a look at this last time as well. Yeah, here we go. So there's the pec there. If I just pause that there we go. So pec major, you can see quite clearly on this cadaveric image the kind of oblique nature and then the twisting nature of the fibers as they come through. And there's your bicep tendon just up there. So it's attaching on the lateral aspect of that bicep tendon, so covering over it. Attaches on your clavicle up here, and then all along the sternum, and then onto some of your ribs. So we've got sternocostal fibers coming across this way, clavicular fibers this way, and it forms the front part there of your armpit. Okay, and we talked about the lat last time, covering the back part of the armpit, okay, and or making up the back part of the armpit, which is the axilla. Yeah, so front part of your armpit is your pec, back part is the axilla. So that's the relationship between the two. Let's just play this through. Okay, we should be back. Sorry about that. Probably right. Problems with microphones. Right. Okay. So yeah, hopefully you got that. Just go back a bit because I think the sound might have cut around here. So yeah, we've got the front part of the axilla there, and then the posterior part of the axilla just there. So the pec and the lat both make up those two walls either side of the armpit. Okay. Right. So there's your pec. Okay, let's have a look at this one. This one does attach onto the scapula and is a pec minor. So if you have a look here, it's again, there's loads of anomalies with pec minor. Sometimes it says that the origins are 3rd to the 5th rib. Sometimes they're a bit higher, sometimes they're a bit lower, but it's around that kind of area, and it attaches onto the coracoid. Okay, and the coracoid can be slightly different shapes, so it might attach onto the front of it, onto the side of it, and that may change its action slightly. But essentially, what it does is it protracts the scapula, so it'll bring it forward, and it will also depress it. Okay, so but it won't be able to depress it far because of the rib cage in the way. What it can also help do is elevate the ribs during forced inhalation. So if the scapula is fixed and you contract the pec minor here, then that's going to bring the rib cage up. Yeah, so shoulder blade fixed, pec minor contracts, is going to pull the ribs up. Yeah, so hopefully that makes sense, because obviously it's kind of weird to think that the scapula is an anchor for anything because it doesn't attach to anything, it's all floating around. So if during forced inhalation, you're going to have other stabilizing muscles holding the scapula in place, whilst that pec minor helps to lift the rib cage. Okay, so that's why it's got that as one of its actions. Let's have a look at this one. Just make sure my sound's still there. Yep. Okay, so this is pec minor. Here we go. Okay, so let's just show you this one. So there's the humerus, just there. Just see the coracoid there. See that slithery piece of tendon just there. That's another tendon that attaches onto the coracoid. And then there's your pec minor, just there. Okay, so you can remember I was saying that it's not as clear as, oh yeah, ribs 3, 4, 5. Look at that. I mean, that's spread out around loads of ribs. Yeah, so it's not as simple as that. That's kind of like an average, if you like. So there's the attachment of the pec minor, and there it is coming up into the coracoid. Okay, there's the attachment just there, coracoid process. And then it will help to depress and protract. All right, let's just go back, watch that one again. So there's your attachment on the ribs. Again, even on the model, it's a lot lower than that. Look, it's coming right down to here. Yeah, so we've got that protraction, depression. Right, that's what pec minor will do. The interesting thing with pec minor, and the useful thing to know, is the stuff that goes underneath it. So if I just play that through a little bit, if I just pause that there. So if you have a look here, there's the coracoid. The clavicle is just above it, and then there's a gap just underneath here. And this is where a neurovascular bundle will come underneath. So we've got nerves and blood coming underneath that pec minor down into the arm. Okay, and that's really important for later when we start to have a look at why people get pins and needles tingling in their fingers. Yeah, that this could be one of the areas where there is what we call a crush point, where something's occluding a vessel or squishing a nerve, which could be irritating structures on the way down. Okay, yeah, just remember pec minor and the attachment, and then when we layer in the structures that go underneath that, it will make sense as to why that might be an issue. Okay, cool. So that's your pec minor. These are some things that can go wrong with pec minor. This is something called Poland syndrome. Affects pec major as well, which I think is the case in this one. We've got obviously a part of the pec major which is missing, and this was missing from birth for this chap, and it's part of the embryological process, which just gets skipped, and we don't really understand why. We know, I can't remember the exact days, but there are exact days which pec major will develop, and something happens on those days, and for some reason in some people it just doesn't develop, but it kind of skips that bit, but then the rest of it's okay. So if you have a look at the rest of his arm, that's all fine, yeah, but it's just that day where you were developing that bit of the pec, it didn't happen for whatever reason. Okay, so, and that's called Poland syndrome, just in case you've not seen it before. Cool. Okay, this is a great one. So do you remember I talking about serrated being one of the words to look out for, like a serrated edge? This is a serrated edge. This is serratus anterior, or serratus anterior, however you want to pronounce it. So it attaches onto your ribs, all in here, and then wraps around your rib cage, and then onto the front part of the inside of your shoulder blade. Okay, so your scapula. So if you, this is a right shoulder. Okay, so imagine that you're kind of looking at it. This is the front of it. Ribs are in front, so the serratus is going to wrap around the ribs and then attach into here, into that area there. Okay, so all along that inside edge. So when that muscle contracts around those ribs, it's going to draw the shoulder blade around the rib cage, and that's why it's called the boxer's muscle. And they have usually a very well developed serratus anterior because of punching and that anterior motion of the scapula. So it's usually well developed in boxers. You might have heard of something as well called a winging scapula, and if it's a true wing, then it's this muscle that's been affected. Now this muscle is innervated by the long thoracic nerve, which we'll have a look at when we do the brachial plexus. But if they have had some kind of injury to this long thoracic nerve, or maybe an illness which has caused an infection or whatever, which has affected the nerve impulses to this muscle, then this muscle helps stick the shoulder blade to the rib cage. So when it's not working, it will wing, okay, and it will come away. And it's one of the things that is quite obvious. Yeah. Sometimes people have what's called pseudo wings, so it looks as if it's coming away, but actually there's no problem with serratus anterior, and all you need to do is just test the muscle to see what happens to the scapula. Because if you do that action, that kind of forward pushing action, and then the shoulder blade can't maintain its position on the rib cage, and it starts to come away, then we know that it's more likely to be a long thoracic nerve serratus issue. Okay, but if that's all strong, but they've still got this kind of wing, then it might just be them, normal for them. Before we go on to that, let's have a look at serratus. This is a difficult one to kind of get your head around, because it kind of wraps from the front to the back, and then attaches on the front of the shoulder blade. So it's like, how does that work? But hopefully you'll be able to get it after seeing this. So there's the image that we've just seen, and here it is in real life. Okay, so this is it here. Yeah. So can you see those serrated edges of that muscle there? It's like it is like the serrated edge of a knife. So try to line up the knife there so it's in line with that muscle. And then let's have a look as it comes around. So as we lift up that arm, there it is there. Okay, so that's your scapula just there. Okay, just underneath there. So the medial border of the scapula has been completely lifted away, and now you can see the whole extent of that serratus muscle, and it attaches all along that medial border just there. Okay, obviously the pec and lat aren't on here, so you can't see those. But the serratus will attach on the front part of the medial aspect of the scapula. All right, so right up into there, and it's actually continuous. If you do have a look at a dissection, it's continuous with your rhomboid muscles. So the rhomboids then carry on that direction onto the spine. So the scapula kind of divides your rhomboid minor, rhomboid major, then there's the medial border of the scapula, and then there's the serratus coming around, and the medial border of the scap kind of sits in between those two sets of muscles. So serratus will bring it forward, and rhomboids will help bring it back. So it glides around the rib cage like that. Okay, so they both work together. There we go. So massive attachment onto the rib cage, all the way back, and that's where it attaches there. Okay, so on that medial border of the scapula, just there. So we're going to get upward rotation. There we go. Okay, so remember when we were talking about that before? We get a movement of that inferior angle. So as you lift the arm up, you'll get this upward rotation of the scapula. That's what serratus will help to do. Okay, it'll help bring about that movement. There's the medial border of the scapula, just there. Inferior angle, just there. Okay, there's your serratus coming in, and it's going underneath the shoulder blade and attaching on the front of that bit just there. Okay, you obviously can't see it because the bone's in the way, but hopefully that makes it all a bit clearer. Here we go. That, and there it is there. Yeah, let me just play that again. I think that's really cool. Yeah, there we go. So medial border of the scapula, attachment onto the ribs, and then as the muscle contracts, it will start to upwardly rotate and start to protract the shoulder girdle as well, so it'll bring the shoulder girdle forward. There. Look at that. Cool. And then obviously the rhomboids on the other side as well, doing the opposite job. Brilliant. Okay. Only 17 muscle. So another one that affects the girdle, but not attaching onto the scapula, is this one, which is subclavius. So sub means under, clavius means clavicle. So this is underneath your clavicle. It helps to stabilize and rotate the clavicle. So it does an important job, because remember I was saying a couple of weeks ago that the sternoclavicular joint is the only joint that attaches the whole arm to the body. So being able to rotate and move that SC joint is really important. So if there's an issue with this muscle, then it may be stopping the excursion of that bone. So let's have a look at where it is. There it is. Here we go. So this is subclavius, underneath the clavicle, just there. So there's your collarbone, and there's subclavius just underneath there, so you can just about make out the muscle tissue. That was it. Let me just pause that there, go back a bit. There we go. That's probably the best shot we're going to get. So you've got first rib there, and then coming up onto the undersurface of that clavicle just there. Okay, so that's your subclavius muscle. So when we were looking at the ligaments last week, especially those SC ligaments, so it's just lateral to those ligaments, and then kind of tucked underneath the clavicle. Okay. Excuse me. Okay. One of the 3 muscles that attach onto the coracoid process. So we've looked at pec minor already. This next one is coracobrachialis. So you can see the coracoid process just there. This muscle then comes straight down and attaches into the middle of your humerus just there. All right. So we've got that direction of pull as well, because obviously muscles can only pull in their fibre direction. So the action of this muscle is to adduct the humerus, and it will also assist in flexing the glenohumeral joint. So if the arm's abducted, it will assist in adducting it, and it will also assist in flexing the glenohumeral joint, so lifting your arm in front of you. Okay, so we've got those 2 main actions. Let's have a look at the muscle itself, if I can. Yeah, there it is. So I've got so many muscles on this one lined up. Hopefully this is it. Okay, we got it. So this is coracobrachialis. There's the image that we've just seen. And this is it for real. Okay, just pause that there. So there's your humerus bone. There's the glenohumeral joint. Coracoid process underneath there. This is your scapula. So there's the medial border there, inferior angle there, and then coming across lateral border just here. Yeah, and then there's your coracobrachialis coming up there. Okay, can you see it kind of wrapping around and then attaching somewhere into there? So that's where your coracoid process is. So onto the coracoid, and then down into the humerus just there. So it will help bring about flexion, and like I said, if the arm's abducted, then it will help to adduct as well. Just show you that again. So there it is there, humerus just there, and then flexion just there. Okay, nearly there. Then we got lateral muscles. Okay, last group of the kind of shoulder girdle region, and we've got the deltoid. And this one's really interesting because I found this one out a few years ago. There was a study done back in 2010 when they did dissection of the deltoid, and but I mean, God, I've been working in gyms for years, like 30 years, and we always talked about anterior, middle, and posterior delts, and actually, there's a lot more than just the three. So the medial portion of the delt is just one band. The posterior posterior deltoid area, is actually split into three. Okay, so there's three clear delineations and split with fascia. Okay, and they found that on this particular study. Obviously, there'll be variations with this, but basically there are more than three. Okay, and then the anterior was split into three parts as well. So the deltoid actually has 7 heads rather than just 3. Okay, maybe there's 6, maybe there's 8. Okay, there's bound to be variations on that as well. But yeah, it's not just as simple as there's 3. And if you have a look, they all attach onto different parts of the top part of the shoulder. So there's your clavicle, there's your acromion just there. So you can see the posterior third one, second one, first one, and then the middle one's attaching onto that kind of edge of the AC, of the acromion, sorry. Then we've got A3, A2, and then A1 coming around onto the clavicle. Okay, so it kind of envelops that lateral part of the shoulder with its different heads all coming down to the deltoid tuberosity, which is on the humerus, just down there. So, but then this is what it looks like in the books. Okay, so we've got anterior, middle, and posterior. And just moving it out of the way, and then coming down onto that deltoid tuberosity there. So it's a useful fact. Whether it will change how you exercise or change what you do, doubt it. Okay, because you can't isolate them and say, oh yeah, I'm working on A3. There's no chance. But yeah, it's just interesting to know that some of the things that were told to us in simplified fashion. When you delve into it a bit more, it's a little bit more complicated, but it doesn't really change what we do. So let's have a look at the deltoid. That should be this one. Okay, and last one for today. So there's the image that we've just seen. So wrapping around that clavicle and acromion area. So there's your clavicle just there. I'll just pause that there. So you can see, I mean, you can see in this one, look at all those different kind of like striations of the muscle. You can see that they're separated by lines of connective tissue. And how far it comes around as well. So wrapping around the spine of the scapula, this one. So it's coming all the way back here, all the way around to the kind of lateral third of the clavicle, and then down onto that deltoid tuberosity just there. So it's a really big old muscle. Yeah. Oh yeah, that's a good point there. Let me just pause that there. So this point here, let me just pause it and get, there we go. So this is the deltoid pectoral groove, this bit here, okay? So on the front of the shoulder, what you'll feel is if you come along the clavicle, around about a third from the edge, and come on in, and then you'll feel a bit of a dip. So it's where the pec major comes in, and then the deltoid comes around, and that's the deltoid pectoral groove. And if you put your finger in there, that's where your coracoid process is, and you should, yeah, there it is. And you won't be far away from the coracoid. You have a bit of a poke and a prod around, and you'll be able to find it quite easy. So that's the deltoid pectoral groove just there. So Claire has just put pliant forwards post anterior shoulder dislocation. Have you covered this on any of the videos? It has specific pain point posterior lateral upper arm, which seems to be at deltoid insertion. I haven't covered anything specifically for that. I was going to suggest a really good website with a a professor with the best name in the world. His name's Professor Funk. I said Funk, Funk. So he is based in Salford, I think, and he runs a website called shoulderdoc.co.uk, and he's got some really good videos of injuries to the shoulder, how the injuries occur, the anatomy of the injuries, and also the surgical repair process and what they do. So it may be worth having a look at Shoulder Doc. Professor Leonard Funk, have a look at his work. He's really good. So yeah, so that's the deltopectoral groove, and then there's your fibers doing their thing. So the back fibers are going to bring your arm into extension, front fibers into flexion, and then middle fibers into abduction. Although it's not as simple as that, okay? They all work together on all of those movements, and they will all be dynamic stabilizers and synergists to each other as you're bringing about those movements, okay? And we'll talk about that next week, definitely, when we're looking at the cuff, okay? When we're looking at the rotator cuff, because it is not as simple as the supraspinatus initiates abduction. Okay, and we'll have a look at that. There are so many other muscles that are contributing to that movement, and it used to be, oh yeah, if they're struggling with the first few degrees of abduction, it must be supraspinatus, and it's not as simple as that, unfortunately. And there's been lots of studies done now to show that that's not the case. Cool. Hopefully you enjoyed that one, and I thought I was going to have time to do the cuff as well, but we'll do that next week. So we'll have a look at the rotator cuff next week. So if you've never heard of it before, then just do a little bit of a browse of the internet or of your anatomy books in readiness for next week. See you then.